On May 6, 2026, the Office of Inspector General added something to its work plan that most seniors will never see reported in the news, but that could put real money back in your pocket. The OIG announced a formal review of whether CMS is adequately tracking refunds of deductible and coinsurance amounts that providers were required to return to Medicare patients, but never did. The review has a project number, it has a scope, and what it describes is a problem that has been sitting quietly in the Medicare billing system for years. When a Medicare claim is adjusted, corrected, denied, or canceled after you already paid your portion of the bill, the provider is legally required under federal law to refund that money to you, not to send you a credit toward a future visit, not to hold the balance in your account indefinitely. A refund directly to you. And the OIG's concern, which is now in writing and on the public record, is that CMS does not have adequate systems in place to make sure those refunds are actually happening. This is not a hypothetical. The kind of claim adjustment this review covers happens routinely. A claim is submitted to Medicare, you pay your deductible or coinsurance, and then something changes. The claim is reprocessed because of a billing error, or Medicare downgrades the service code, or the claim is denied on secondary review and a new amount is determined. The provider's obligation to bill you changes. The amount you owe goes down. And if you already paid more than you now owe, federal law says you are owed the difference. Most seniors never know to ask for it. Most providers never volunteer it. And now, the OIG has put the entire system on notice that it is going to look at whether these refunds are being tracked and returned. I am going to walk you through what this means for you, what types of claims most commonly generate this kind of refund right, what the relevant law says, and exactly what to do to find out if you are owed money and how to get it back. Before we get into it, I want to hear from you. Have you ever paid a hospital deductible or a Medicare coinsurance and then received a confusing adjusted statement afterward that suggested the original amount was different? Drop it in the comments. A lot of people have been through this and do not realize there may be a refund attached. And before anything else, everything I share here is educational, not personalized legal or financial advice. For guidance on a specific situation, contact your SHIP office, which is free in every state. With that said, let us get into it. My name is Walter Barron. I am a State Bar licensed estate attorney, and for more than 15 years, I have sat across the table from families navigating Medicare billing disputes, denied claims, and the money that should have come back but never did. Let us get into it. Let me start with the foundational rule because it is one that most patients have never seen stated plainly. Under federal Medicare requirements, when a provider collects a deductible or coinsurance from you, and that claim is later adjusted or denied, meaning the amount Medicare owes and the amount you owe both change, the provider is required to refund the excess to you, or in some cases, to your secondary insurer. This obligation exists in federal regulation. It is not a courtesy. It is not something the provider gets to decide case by case. It is a legal requirement attached to the provider's participation in Medicare. Providers who participate in Medicare agree to a set of billing and refund obligations when they enroll in the program. The obligation to return credit balances to patients is one of them. What the OIG's May 2026 Work Plan review is investigating is whether CMS is doing its job of monitoring whether providers are actually complying with this requirement. The concern is specific and on the record. CMS may not have adequate systems in place to track whether these refunds are happening, which means that a significant number of providers may be carrying credit balances that belong to patients, and neither the patients nor Medicare's oversight system knows about them. The money is sitting in the provider's accounts. It has not been returned. And without a formal tracking system, it may never be. The OIG's formal project is titled CMS's Tracking and Refunds of Deductible and Coinsurance Amounts for Adjusted and Canceled Medicare Parts A and B Claims. It was announced May 6, 2026, project number OAS-26-06-055. The scope of the review covers Part A providers specifically: hospitals, skilled nursing facilities, hospice programs, and home health agencies. These are the providers that tend to involve the largest single claim amounts, which means the largest potential patient responsibility on the original claim, and therefore the largest potential refund when that claim is adjusted downward after the fact. This is not a new legal requirement that the OIG invented in May 2026. The obligation has been in the Medicare regulations for years. What is new is that the OIG is now formally auditing whether the system for returning that money is actually working, and the fact that they felt the need to open a formal review is itself telling. If the system were working reliably, there would be nothing to audit. Now, let me tell you when this kind of claim adjustment actually happens, because the situations are more common than most people realize, and each one generates a legal refund right that very few patients ever pursue. The first and most common situation is a billing error on the original claim that is corrected after the fact. This happens because hospital billing is extraordinarily complex. A hospital stay can generate dozens of individual billing codes for the admission itself, for each procedure, for each test, for medications, for the attending physician's services, for specialists who came in. A claim might go out with the wrong diagnosis code, the wrong procedure code, or the wrong service classification. Medicare processes it, you receive your share of the bill, you pay it, and then the error surfaces during an internal audit, through a billing review triggered by Medicare, or because the provider itself catches a discrepancy during a routine compliance check. When the corrected claim generates a lower patient responsibility, the overpayment belongs to you. The provider owes you the difference. Federal law is explicit on this point. The second situation is a claim that is denied by Medicare on a secondary review that happens after payment. This is less intuitive, but it happens regularly. You pay your Part A deductible for a hospital stay. Medicare pays the hospital. Weeks or months later, a Medicare contractor reviews the claim and determines that the billing did not comply with Medicare requirements. Perhaps the stay did not meet the 2 midnight threshold, or a procedure was miscoded, or documentation was insufficient to support the claim as submitted. Medicare adjusts its payment. The claim is reprocessed. The patient cost-sharing amount changes, and if you already paid the original amount, the difference is a credit balance sitting in the provider's system with your name on it. The third situation matters particularly for anyone who has been in a hospital recently and then received a large bill from a skilled nursing or rehabilitation facility. It is the reclassification of a hospital stay from inpatient to observation status that happens after you have already been discharged. When a stay is reclassified, either through an appeal, a utilization review, or a retroactive audit, the cost-sharing structure changes entirely, from Part A coverage to Part B coverage. The deductible you paid under Part A may not be the same as what you would owe under Part B. And depending on the specific reclassification and your secondary coverage, the difference can flow in either direction. But in many cases, it creates an overpayment that should come back to the patient. The fourth situation is a claim that is canceled because of a duplicate billing error. If a service was billed twice, once by the hospital's billing department and once by the attending physicians group, for example, or twice by 2 internal departments on the same date of service, and you paid your cost share on both versions of that claim, and one of the duplicates is later identified and canceled, the canceled claims portion of your cost share belongs to you. The OIG's comprehensive error rate testing program has flagged duplicate billing as one of the most consistently identified improper payment categories in Medicare fee-for-service. In fiscal year 2024, the improper payment rate across Medicare was 7.66% of total spending, a number that reflects in part exactly this kind of duplicate and corrected claim problem. When duplicates are caught and canceled, patient refunds are required, but the patient has to know to ask. There is a second piece of this that goes beyond individual claim corrections, and it is one of the most consequential unclaimed financial opportunities for Medicare beneficiaries today. It is worth spending time on it here because it is connected to the same underlying problem: money that people are entitled to that the system never tells them about. It is the Medicare Savings Program, and between 2 and 3 million people who are currently eligible for it have never enrolled. The Medicare Savings Program is a set of 4 federally mandated programs run by state Medicaid offices that help people with limited income cover their Medicare costs. The most generous level, the Qualified Medicare Beneficiary Program, called QMB, covers the Part B premium, the Part A premium if applicable, deductibles, copayments, and coinsurance. That means for people who qualify, every Medicare cost share we have discussed in this video goes to zero. The hospital deductible, the nursing facility coinsurance, the Part B 20%, all of it covered. And here is the piece that connects directly to what we just covered about claim adjustments and refunds. When someone is enrolled in QMB and a provider collects a deductible or coinsurance from them, that collection is itself a violation of federal law. QMB enrollees are legally protected from being charged Medicare cost sharing. If a provider charges a QMB enrollee a deductible or copay, which happens constantly because many providers do not check QMB status carefully, the enrollee is entitled to a refund of the amount collected. The OIG has flagged QMB billing violations as a persistent compliance problem. The Medicare Rights Center maintains a helpline specifically for people who have been improperly charged while enrolled in QMB. The NCOA and MACPAC have both documented that as many as 2 to 3 million people who qualify for the Medicare Savings Program are not enrolled, representing between $3.96 billion and $5.94 billion in forfeited benefits annually. The Part B premium alone is worth $202.90 per month in 2026. A full year of MSP coverage returns $2,434.80 in premiums that would otherwise be deducted from your Social Security check before you ever see it. Stack in extra help for prescription drugs, which the Social Security Administration estimates at $5,700 in annual value, and the combined benefit for people who qualify for both reaches approximately $8,000 per year. That is $8,000 in costs that eligible people are currently absorbing because they did not know to apply. The income limits are meaningfully higher than most people assume. For a single person, the most generous level, QMB, covers incomes up to roughly $1,350 per month in most states. For a married couple, the limit is around $1,824. Those numbers include many people living primarily on Social Security. And critically, many states have now eliminated asset tests entirely or raised the asset limit significantly, meaning a paid-off home or a modest savings account may no longer disqualify you the way it once did. If the last time you heard you did not qualify was more than 3 years ago, your state's rules may have changed since then. The application is a single-page form submitted to your state Medicaid office. The fastest path is to call your local SHIP office and ask to be screened on the phone. The call takes about 15 minutes. The counselor will pull your state's current income and asset limits, walk through your situation, and if you appear to qualify, help you complete the application on the spot. There is no cost, and if you have been paying Medicare premiums for years while potentially qualifying for coverage that would have eliminated those charges, the number attached to what was left unclaimed is real. Now let me put both pieces together into the 3 things you should do this week, because understanding the problem is only useful if it leads somewhere concrete. The first thing to do is look at every Medicare summary notice you have received in the last 2 years and read each one carefully. You can pull these from mymedicare.gov under the Claims section or request paper copies by calling 1-800-MEDICARE. You are looking for any claim where the column labeled Medicare Approved Amount or the Patient Responsibility column appears different on a later statement than it did on an earlier one for the same date of service. That discrepancy signals an adjustment. If the adjustment reduced the amount you were supposed to owe, And if you already paid the original amount, there is a credit balance somewhere that belongs to you. Write down the provider name, the date of service, and the original amount you paid. Then call the provider's billing department with that information and ask directly, has this claim been adjusted by Medicare since it was originally submitted? And if so, does my account show a credit balance? Ask when the refund will be issued and to what address. Ask for the answer in writing. The second thing to do is call the billing department of any hospital or skilled nursing facility where you or a family member received care in the last 12 to 18 months and ask one specific question. Has the Medicare claim from that stay been adjusted, reprocessed, or corrected since it was originally submitted? If the answer is yes, and the adjustment reduced the patient responsibility, ask directly whether a credit balance exists. Providers are not always proactive about returning these balances. Some hold them for extended periods. The OIG's May 2026 Work Plan Review, Project OAS-26-06-055, is specifically investigating whether CMS is tracking this. Mentioning the OIG review by name and project number during that call signals to the billing department that this is a documented, audited compliance obligation with federal scrutiny behind it, not a casual inquiry. That distinction changes the response. The third thing to do, and this one has the potential to be worth more than the other two combined, is to call your local SHIP office this week and ask them to screen you for the Medicare Savings Program. The call takes about 15 minutes. There is no cost. If your income as a single person is under roughly $1,350 per month or under $1,824 as a couple, you are worth screening. If your state has removed asset limits, a paid-off home does not disqualify you. And if you qualify for the QMB level of the program and have been paying Medicare cost-sharing charges, deductibles, copays, coinsurance, those charges were illegal under federal law from the moment you became eligible. You may have grounds to recover them. The Medicare Rights Center National Helpline at 1-800-333-4114 handles QMB billing violations specifically and can advise you on what is recoverable in your state. The government's Audit Division opened a formal investigation in May 2026 because the system for returning patient overpayments is not working reliably. That investigation does not return your money for you. It only confirms, in writing and in public record, that the obligation exists and that oversight is now watching. The forms exist, the rights exist. The process for claiming both is available to you today. The only gap is whether you know to use it. If you know someone over 65 who has had a hospital stay in the last few years, or who is paying Medicare premiums they may not need to pay, please share this with them. It will cost you nothing. And it may be the reason real money comes back to them. Money the system collected, kept, and never volunteered to return. Thank you for watching.